Hello, today we will discuss atrial fibrillation. Atrial fibrillation is often asymptomatic, meaning that you don't know that you'll have it. However, some may experience symptoms such as palpitations, weakness, dyspnea, i.e. difficulty in breathing, presyncope, which is a state of lightheadedness, muscular weakness, blurred vision, and feeling faint. Atrial thrombi can form, which may dislodge and result in an embolic stroke. An irregularly irregular jugular venous pulse with loss of an A wave can be felt when palpitated in the neck region. And finally, a pulse deficit, i.e. is the difference between heartbeats and the peripheral pulsations. This may be present because the left ventricular stroke volume is not sufficient to produce a peripheral pressure wave at fast ventricular rates. Diagnosis of atrial fibrillation is mainly made by ECG. The ECG findings in atrial fibrillation include absence of P waves, presence of fibrillatory waves, so-called F waves between QRS complexes. These F waves are irregular in timing as well as in morphology. Irregularly irregular RR intervals is another ECG finding. The RR interval is the interval between the peak of one QRS complex to the peak of the next. Other investigations that aid in the diagnosis of atrial fibrillation include echocardiography and thyroid function tests, which are especially important in the initial evaluation. Echocardiography is done to assess structural heart defects, such as left atrial enlargement, left ventricular wall motion abnormalities suggesting past or present ischemia, valvular disorders, and cardiomyopathy. It is also important to identify risk factors for stroke, such as atrial thrombus or a complex aortic plaque. Atrial thrombi are more likely to be found in an atrial appendages, where they are best detected by transesophageal rather than transthoracic echocardiography. Thyroid function tests can be found to find out if you have hyperthyroidism, because hyperthyroidism patients have a higher risk of getting atrial fibrillation. Atrial fibrillation can be classified into four types. Paroxysmal atrial fibrillation, which is an episode of atrial fibrillation that terminates spontaneously or with intervention in less than 7 days. This means that there's a possibility for these episodes to reoccur. Persistent atrial fibrillation is when an episode of atrial fibrillation lasts for more than 1 week. Long-standing persistent atrial fibrillation refers to continuous atrial fibrillation that lasts longer than 1 year, but there's still a possibility of restoring sinus rhythm. Lastly, permanent atrial fibrillation, which refers to patients in which efforts to restore normal sinus rhythm have failed. The longer the atrial fibrillation is present, the less likely is spontaneous conversion and the more difficult in cardioversion because of atrial remodeling. Most common causes of atrial fibrillation are hypertension, coronary artery disease, cardiomyopathy, mitral and tricuspid valvular disorders, hyperthyroidism, and binge alcohol drinking, which may give rise to holiday heart syndrome. This is an irregular heartbeat pattern presented in individuals who are otherwise healthy, but sometimes follow excessive alcohol consumption. Less common causes of atrial fibrillation include pulmonary embolism, atrial septal defects and other congenital heart defects, chronic obstructive pulmonary disease, or COPD, myocarditis, which refers to the inflammation of the heart muscle, and pericarditis, the inflammation of the pericardium. Now, let's move on to the treatment of atrial fibrillation. If significant underlying disorder is suspected, patients with new-onset atrial fibrillation may benefit from hospitalization, but those with recurrent episodes do not require hospitalization unless other symptoms suggest the need for it. Once the causes have been managed, treatment of atrial fibrillation focuses on ventricular rate control. Rate control can be achieved with drugs or AV node ablation. Patients with atrial fibrillation of any duration require rate control, typically to less than 100 beats per minute at rest, to control their symptoms. For acute paroxysm of rapid rates like 140 to 160 beats per minute, intravenous AV nodes blockers are used. Rate control is also important to prevent Tachycardia-induced cardiomyopathy. Word of caution: AV node blockers should not be used in patients with Wolff-Parkinson's-White syndrome when an accessory AV pathway is involved. This is indicated by wide QRS duration. These drugs increase frequency of conduction via the bypass tract, possibly causing ventricular fibrillation. Ventricular fibrillation is the most serious cardiac rhythm disturbance. The lower chamber quivers, and the heart can't pump any blood, causing cardiac arrest. Beta blockers, for example, metoprolol and esmolol, are also preferred in acute paroxysm. If excess catecholamines are suspected in a thyroid disorder and exercise-triggered cases, non-dihydropyridine calcium channel blockers, for example, verapamil and diazepam, are also effective. Digoxin is the least effective but may be preferred if heart failure is present. These drugs may be used orally for long-term rate control. When beta blockers, non-dihydropyridine calcium channel blockers, and digoxin separately or in combination are ineffective, amiodarone may be required. Prevention of thromboembolism during rate control. If atrial fibrillation has been present for more than 48 hours, patients should typically be given an oral anticoagulant. This is because, regardless of the method used for cardioversion, it increases the risk of thromboembolism. Anticoagulation should be maintained for more than 3 weeks before conversion, or it can be given for a shorter time before conversion if transesophageal echocardiography does not show left atrial thrombus. Rhythm control can be achieved with synchronized cardioversion, drugs, or ablation. For acute conversion, synchronized cardioversion of drugs can be used. Drugs for conversion of atrial fibrillation to sinus rhythm include class LA, LC, and triple L antiarrhythmic drugs. These drugs should not be used until rate has been controlled by a beta blocker or non-dihydropyridine calcium channel blocker. These converting drugs are also used for long-term maintenance of sinus rhythm. The class LA antiarrhythmic drugs include procainamide, quinidine, and disopyramide. Class LC antiarrhythmic drugs include flecainide and propafenone. Class triple L antiarrhythmic drugs include amiodarone, dofetilide, dronedarone, ibutylide, and sotalol. It is important to continue anticoagulation for at least 4 weeks after cardioversion. Many patients may need chronic anticoagulation. Cardioversion may be done without prior anticoagulation if the patient has non-valvular atrial fibrillation and is not at high risk of a thromboembolic event. Ablation is a surgical procedure which works by scarring or destroying heart tissue that is responsible for the bad rhythm. Ablation is done for patients that can't take rate-controlling drugs. Ablation procedures that isolate the pulmonary veins from the left atrium can prevent atrial fibrillation without causing AV block. This procedure is often reserved for younger patients with drug-resistant atrial fibrillation who have no significant structural heart disease. Long-term measures to prevent stroke are taken for certain patients with atrial fibrillation. Patients with rheumatic mitral stenosis and those with mechanical artificial heart valves are at high risk of stroke. Therefore, these patients are treated with warfarin. We can use 2 tools to evaluate risk factors for stroke and bleeding. The CHA2DS2 score is used to evaluate the risk of stroke, and the HAS-BLED is used to evaluate the risk of bleeding. High CHA2DS2 score means that increased risk of stroke. The acronym CHA2DS2 means C for congestive heart failure, H for hypertension, A for age more than 75, D for diabetes, S for stroke, V for vascular disease, A for ages 65 to 74, and S for female sex. Number 2 next to A and S just means that we give 2 points to those risk factors. 1 point is given for every risk factor except for stroke and when the patient is more than 75 years old. These are given 2 points. Note that when the patient is 65 to 74, only 1 point is given, and when the patient is less than 65, then no point is given. Here's a picture showing the CHA2DS2 score. These are the risk factors for stroke. Starting with the upper left picture, we have congenital heart failure, hypertension, age more than 75, which is given 2 points, age 65 to 74, which is given only 1 point, and then in the lower left picture, we have diabetes, then stroke, which is also given 2 points, then we have vascular disease, and finally, female sex. Situations where antithrombotic therapy is absolutely contraindicated The less atrial appendage must be surgically ligated or closed with a transcatheter device. The VAS score dealt with the risk of stroke, but the HAS-BLED score deals with the risk of bleeding. The acronym HAS-BLED means H for hypertension, A for abnormal renal and liver function, S for stroke, B for bleeding, L for labial INR, E for elderly, and D for drugs and alcohol. 1 point is given for each risk factor. These are the risk factors for bleeding. Starting from the upper left picture, we have hypertension, kidney disease, liver disease, stroke. Then in the lower left, we have bleeding disease, patients over the age of 65, alcohol and anticoagulation medications like warfarin. All these risk factors are given 1 point each. Thank you for listening.